retire in 24 hours. Let me see. So as agreed, while other guys get to join, when we were to discuss nephrotoxic agents in terms of medications and their implications. Anyone who wants to lead that particular discussion before we get to discuss nutrition complications? If Sally is in class. Anyone? Um, Anyone who had a read of any nephrotoxic agents? None among the 22 of us. Um, okay. I think I'll just proceed with today's class. As soon as you guys are ready to discuss nephrotoxic agents, we'll be able to discuss it. Until then, allow me to continue with today's class, which in this case entails um, nutrition complications. Is my screen visible to all?
Yes, it is.
Excellent. Let me just close the door. Okay. So, like I promised, 2 days ago, I think we'll be talking about nutrition complications in CKD, and you'll note that as patients progress through the stages of CKD, nutritional requirements are altered, and the metabolism of protein, water, salts, in this case sodium, potassium, and phosphorus are affected, either by going up or by seriously going down. And these changes lead to ineffective energy generation despite adequate intake of protein and carbohydrate substrates. In more extreme manifestations, you'll find that these alterations in nutrient utilization cause what we call uremic malnutrition. That basically being defined as a syndrome that is distinct from malnutrition caused by inadequate nutrient intake, and with, of course, urea being very high. Yeah? So factors will affect the rate of progression of CKD, and you'll also note that these are the factors that uh, are also nutrition complications include hypertension, acute insults from nephrotoxins or decreased perfusion, proteinuria, increased renal ammonogenesis with interstitial injury. Also very common with interstitial renal disease, hyperlipidemia, hyperphosphatemia with calcium phosphate deposition, and decreased levels of nitrous oxide. Now, a majority of the complications of nutrition complications are also the complications of chronic renal failure. So, by the fact that they're actually happening in a CKD patient, they contribute to nutrition complications by a large factor. This will include volume overload, you'll have hyperkalemia, metabolic acidosis, hypertension, anemia, malnutrition, hyperlipidemia, and anemia here is iron deficiency anemia of chronic disease, bone renal disease, pericarditis, anorexia, nausea, vomiting, fatigue, and hyperphosphatemia. So looking at them one by one, we start with volume overload. So in this particular case, you're going to have sodium and intravascular volume balance being maintained via homeostasis mechanisms until you realize that the GFR has actually gone down to between 10 to 15 mLs per minute. In this case, the patient will have mild to moderate chronic renal failure now showing itself despite being in relative volume balance. And this will there's less capability of responding to rapid infusions of sodium, and therefore the patient is actually prone to volume overload or fluid overload, if you like. So how do you manage that? Um, the patients will generally respond to a combination of dietary sodium restriction, dependent on the staging. Remember, we talked about that, I think, on Monday. So, dependent on the stage, you have to calculate the stage first, figure out where the GFR is, and then you can to restrict. So, dietary sodium restriction and diuretic therapy. In this particular case, you diuretics. Loop diuretics will likes of Lasix, torsemide, brand names. Now, I mean, chemical names is furosemide and torsemide. Brand names being Lasix and diurite. So that is how you get to manage fluid overload. But at the same time, dependent on how your patient presents and the urine output, there's also that factor that must be placed in. So you have to get to calculate the total output. Are they in the required amount? Because now the requirement is zero point 0.5 mLs per kg per hour. All right, so that is the requirement. If they are in that, then you have to push loop diuretics, of course, because they're in overload, but then the output is also okay. So that factor, it should not be forgotten. The output must be considered. The other factor that gets to come and complicate nutrition matters of this particular class of patients is metabolic acidosis. And in the PCT to excrete the endogenous acid into urine in form of ammonium. Now, in a very advanced chronic kidney disease, or if you like, chronic renal failure, accumulation of phosphates, sulfates, and other organic anions also cause acidosis. And the result will be worse bone renal disease and loss of lean body mass and weakness. So, how do we get to manage metabolic acidosis? Of course, alkali therapy will be given to maintain the serum bicarbonate above 22 millimoles per liter. Now, how you get to actually figure this out is by having ABG results, arterial blood gas results. So you have GAB, PCO2, and the lights. Yeah, they'll be there. The point here is to maintain the bicarb above 22 millimoles per liter. Sodium bicarbonate is the alkali of choice most of the time, and this is given as zero point 0.5 to 1 milliequivalents per kg per day. And sodium citrate is the other alkali of choice, especially in those who on antacids or who cannot tolerate sodium bicarbonate. So that will be given. The other way of managing acidosis is actually initiating dialysis. Remember the IAEOO, metabolic acidosis, electrolyte imbalance, indigestion, and intoxication, fluid overload, and then uremia. So the other way of managing acidosis is is dialysis, not metabolic acidosis. Yeah. So we've covered volume overload. We figured how that should be managed. Yeah. So we've got dietary sodium restriction and diuretic therapy, thanks to the nephrologist and MOs for that. The dietary sodium restriction will totally be dependent on the stage of this patient's disease, and you also look at it from the perspective of what do you call it? The levels of sodium. Figure out what type of hyponatremia they're having. While don't restrict sodium in a patient who has hyponatremia. That is the thing. You need to figure out what type of hyponatremia they're having. We've got three types of hyponatremia in the process. Figure those out, yeah? Then we've talked about metabolic acidosis, and we've already noted that with this particular class of patients, the balance of the negative charge and the positive charge is, off the chart. So the point here is to maintain the serum carbonate above 22 millimoles per liter. You have two choices of alkalis. You've got sodium bicarbonate and you've got sodium citrate. The citrate here is used especially for the patients who are on antacids or who cannot tolerate the bicarb. And the other way of managing metabolic acidosis is dialysis. I hope to that point that is understood. Now, the other complication is hyperphosphatemia. And phosphate retention will basically begin at early CKD. When the GFR is falling, then you'll have less filtered phosphates, and that means less secretion. And you'll also note that the serum levels are not going to necessarily rise immediately because there's going to be an increased PTH secretion, which is normally the negative feedback mechanism of the kidneys. And as a result, you'll have increased renal excretion. But in the case where you've got a positive feedback mechanism, secondary hyperparathyroidism is what normally happens. And as a result, you'll have increased serum levels of phosphates. So how do you get to take care of that? How do you actually handle hyperphosphatemia? One, you'll have to deal with secondary hyperparathyroidism, which will develop secondary to hypocalcemia, and decrease renal synthesis of 1,25-dehydroxy, in this case, calcitrol, or 1,25-dehydroxy vitamin D. And the other reason would be hyperphosphatemia, right? That is how you'll ensure you handle secondary hyperparathyroidism. Correct hypocalcemia. Ensure the patient is on calcitrol and deal with hyperphosphatemia. So how do you deal with hyperphosphatemia? You'll have to ensure there is dietary restriction of intake, only going all the way to 800 milligrams per deciliter, not exceeding that. All right. And you're targeting serum levels of 0.87 to 1.49, or for some other papers would say 1.13 to 1.78 millimoles per liter. But where I work, we use 0.87 to 1.49. So one, you've done dietary restriction, of course, ensuring just a maximum intake of 800 milligrams per deciliter. Two, you prescribe oral phosphate binders. So you remember when I mentioned you can only use calcium-oriented actolsans? Yes. In this case, it will be calcium carbonate or acetate. Number two, you can ensure you prescribe Sevilama. Sevilama is a non-absorbable cationic polymer that binds phosphates, and the bond here is covalent, so it's not breakable. And Sevilama is prescribed at 800 milligrams TDS, 800 milligrams TDS, and it's taken with meals. And it is taken with meals. So, like I mentioned a couple of days ago, we've got two forms of Actol. We've got the magnesium one, which is readily available, which is actually the common one, and then we've got the calcium one. So what we are targeting is the calcium one. We are absolutely avoiding the magnesium agents, and we are avoiding calcium citrate as well. All right. So that is how we manage hyperphosphatemia. One, dietary restriction of intake of phosphorus up to a max of 800 milligrams per deciliter. Two, you prescribe oral phosphate binders, either as a calcium salt or as the Diama 800 milligrams TDS. Please note that the calcium salts are also TDS with meals, yeah? And three, you ensure that you avoid any agents that have a hydroxide in it, magnesium agent, or a calcium citrate. So that is how you manage hyperphosphatemia. So we've handled three: fluid overload, metabolic acidosis, hyperphosphatemia. Complication number four will be renal osteodystrophy, which typically leads to renal bone disease. And in this case, you have incremental lesion when serum levels of PTH remain elevated. Kind of the reason why you have to deal with the elevated PTH levels on the other side when phosphorus is involved. Osteomalacia, primarily from predominantly is on chronic peritoneal dialysis. Chronic, that means they're going to use it for a very long time. You might want to be very careful because then they are at risk of developing adenomic bone disease. Amyloidosis, which comes from beta 2 microglobulin accumulation in patients who have required chronic dialysis for at least 8 to 10 years, manifesting with cysts at the end of the long bones. So the long bones here being tibial fibula, the femur as well. You might want to be careful with this particular class of patients, those who are on chronic dialysis, because then developing this becomes very easy, and it's from accumulation of the beta 2 microglobulin accumulation. And this will manifest as enteritis due to
Hello, Grace.
yes.
Grace, you're on another slide, but your slides are not moving. We are still on hyperphosphatemia management.
I can hear you. I'm at
Yes,
you're there.
hyperphosphatemia management.
Can you see the screen
That's the one on
now?
the screen. It's still the same.
Even now?
Yes.
Okay,
No,
let me
actually, it
stop
has
sharing.
changed. It has it has
Again.
changed.
Okay, I'm resharing again anyway.
Okay.
Can you see renal osteodystrophy now?
Yes.
All right, excellent, excellent. All right, thank you, Noreen. So you're with me here when I've talked about the fibrosa, osteomalacia, adenomic bone disease, and amyloidosis. Are we good there?
Yes.
Someone kindly
Would you
respond.
kindly just
Thank you,
repeat what
Marcy.
you
Thank you,
said?
Marcy. All right. Concerning what exactly, Betty?
Mm. I didn't get anything on that slide.
Debbie, what exactly would you like?
Just talk about melodiosis again, please,
Or everything on this particular slide?
if you can.
Yes, yes, yes. Thank you.
Yes.
Okay. So
Kindly, thank you.
yes, but of course. All right. So amyloidosis happens and will take place, or will be, no worries. Is a condition that will be manifesting to take 10 years, okay? And this is contain beta microglobulin. Basically, the beta 2 microglobulin has accumulated, forming cysts at the end of long bones. Long there being tibia, fibula, Betty.
Yes, I'm with you, Grace. I'm with you.
So you understood what that is. Excellent. Can you see my next
Yeah.
slide then? Renal osteodystrophy
No.
management.
No,
Is
No.
it visible? Excuse me, Grace.
not yet.
Yes.
Grace,
Sorry, good people. I'm back. Yes, Lillian, I hear you, my dear. I'm back. Am I audible enough now?
Yep.
Brilliant. Can you see my screen?
Yes.
So we are looking at renal osteodystrophy management. So
Yes.
one, we have to manage hyperphosphatemia. Well, that will ensure that we target the levels of PTH, parathyroid hormone here, to be normal, okay? So that we don't get the damages that come with it. And in this case, the osteotitis fibrosa. Number two, we prescribe calcitrol and vitamin D analogs. And number three, we get also to look at calcimimetics. All right. So that is how we get to manage that. But remember, all these factors will be implemented dependent on how the workup of your patients present, how you examine them. Of course, you're looking at nutritional focused, physical
Yes.
exam. You've ordered for X-rays, especially for
No.
now the patients who have been on chronic dialysis for 8 to 10 years. You're also being keen to look out for all these factors. Sawa sawa. Someone has unmuted. Kindly mute. Complication number 5, I believe, is hypertension. Well, the sad reality of our patients is that 80 to 85% of CKD patients have hypertension, and some will go all the way to a type we call resistant hypertension. So why this happens is because we've got a distorted RAS system, renin, angiotensin, aldosterone system, which leads to volume expansion, and that contributes to BP rise. So optimal BP unknown, but now it's currently known. The recommendations being below 130 over 80. And hypertension management, as far as we are concerned, we'll definitely be talking about looking at a volume load. We are talking about sodium restriction dependent on staging and dependent on the serum levels. And then three, we have to know the combination of antihypertensive agents, beginning with AC inhibitors, angiotensin converting enzyme inhibitors, or angiotensin receptor blockers with a diuretic. And the diuretic here will also be precise. For example, loop diuretics have a tendency of ensuring there's loss of both water and sodium because they stimulate the aldosterone hormone. All right, so that will be noted. And diuretics too will be useful to achieve the patient's dry weight. All right. Now, thiazide diuretics at low GFR are not very effective at the usual doses. So you'll note some of your CKD patients will not have HCTZ, hydrochlorothiazide, or anything ending with a thiazide, now in this case being a thiazide diuretic. So you'll note some of them, especially those with a low GFR of anything below 15, HCTZ is normally removed and they're left with, for example, an AC inhibitor or an ARB. In this case, they're left with losartan H, or they're left with NR-April, the Aprils in this case. But ARBs are what we normally use mostly, with either Lasix, also known as furosemide, or torsemide. Lasix is more readily available. I mean, it's 3-bobatab, 40 milligrams in this case. So it's readily available to our clientele, and you'll find that more often than not. So hypertension management is very broad by the simple fact that we do not limit ourselves to antihypertensive agents only. We are also looking at why the hypertension. Is it cardio-oriented? Is it renal-oriented? Is it hepato-oriented? So please open your mind up to that, because that will happen sometimes for this class of patients, and then be able to note from wherever it's coming from. You'll be able to do sodium serum levels. You'll be on the lookout for fluid overload. Recently, I had a patient who showed up with atherosclerosis, and the pressures were unmanageable. I think we nearly maxed out on everything until we figured it was actually atherosclerosis, and there was a lot of calcification around the arteries and the veins of both lower limbs. And when the patient was started on a statin, high dose statin, of course, and given the regimen for walking, physio in this case, the patient improved remarkably. We've actually had to remove some of the antihypertensives because he was crashing on dialysis as a result. So open up your mind. There's so many things that actually will cause hypertension in this class of patients. And if we just um, put ourselves in the block of Akona CKD, and that is it. Now, we need to broaden our mind and figure out what exactly is actually pushing these patients up into resistant hypertension. So that is how we get to take care of that particular complication. Complication number 6, if I am not wrong, will be anemia. And half the time, our patients will start, when CKD is starting to show itself, they'll start with normocytic, normochromic anemia, right? So normal HCT, normal MCV levels, but a low HP, all right? So this increases from a decreased renal synthesis of erythropoietin, which is a necessity and which is only done at the kidneys. So you'll also note that the RBC levels on your full hemogram or CBC with differentials is also decreased. And why? Because thanks to decreased renal synthesis of erythropoietin, there is decreased RBC survival. So other things that will increase anemia tendencies will be tendency of bleeding, as well, which is increased from the uremia-induced platelet dysfunction. All right. So be also on the lookout for your platelets, not yours. Okay, or yours when you're unwell and when you're figuring your life out. But when your patients are involved, be on the lookout for platelet dysfunction, which is induced by elevated urea levels or presence of uremia for that matter. So how do we manage anemia itself? First and foremost, you must work with the target. Of course, HB above 11, and the patients will receive 80 to 120 units per kg weekly. So basically between 2,000 and 5,000 international units per week. The equating is what is given, and iron in patients on EPO will, or with reduced iron stores, will receive IV iron, in this case as iron sucrose, a maximum of course, of 200 milligrams IV, and it's either given directly into the bloodlines on dialysis, or it's given via normosalia 500 mLs. And they can also receive 200 milligrams elemental ferrous sulfate iron per oral daily. All right, so that is per oral daily. But remember, they must be on EPO. That's a fact. You can give the much iron you can, but if a patient is having CKD with decreased GFR, you will definitely expect that the kidneys are not synthesizing erythropoietin. So the factor that you consider first is administration of EPO, and then you can give your iron. Then you are absolutely sure that there's going to be RBC survival increasing both, as well as the HB at the end of the day. All right. Please note that and I'll repeat this again. However much we give iron, without considering EPO, we've not done much. All right, and we can actually place these patients into iron overload, which is something else that's a damage. Okay, so we must consider. All right, so we're giving iron, but how much EPO is this patient receiving? All right, so that has to always be at the front of our minds, not even at the back, at the front, because those two must go together. Complication number 7 or 8 has already lost count. Dyslipidemia.
Eight.
Common. Someone said a word? You said number 8. I see maybe
Yes,
left.
that's number 8.
Excellent. Number 8 it is. All right, so number 8 is dyslipidemia, which is very common, and half the time it will present itself as hypertriglyceridemia, even with a very normal total cholesterol. So there's debate for on diet therapy versus drug therapy, especially with patients who have increased cardiovascular risk factors. So always statins are prescribed, and you're considering this that um, as far as this lipidemia is concerned, CKD will have an equivalent damage as chronic heart failure in this or heart disease. So you must target a low LDL always, and statins do very well when it comes to that. All right. So that is as simple as that. You must target a low LDL. So you have to combine both statins and diet therapy. They're not left behind. You cannot separate those two. Because at the end of the day, as much as we know 90% of cholesterol is made by the body, we have to consider triglycerides coming from beta oxidation of lipids in the system. Complication number 9, I know this is going to be interesting, sexual dysfunction. And yes, that is very common with our patients. At least 50% of men with chronic renal failure will have sexual dysfunction. And this is secondary to decreased blood perfusion, well, and hypertension as well. Females will have menstrual and fertility problems, of course, and half the time there are poor pregnancy outcomes for patients who get to have CKD on dialysis and or even CKD alone without being on any modality and are pregnant. So they require thorough multidisciplinary approach. And I mean, I'm repeating this again, thorough multidisciplinary approach. Psychologists involved as well because of the outcomes as a result. So anything according to this particular class of patients, anything that is sexual dysfunction, they have to be prepared for it. I mean, it has to be in the counseling. During the renal counseling, the patient has been discovered with CKD of some sorts, they have to be cancelled, the complications that will be expected. So by the time it's 2, 3 years down the line, or even 1 year down the line, and this comes up, you'll be able to handle it from a perspective of them knowing and not necessarily not them knowing. The other complication that comes with the other nutrition complication that comes with CKD is GI, anything GI. So one, they easily get GI edema, and that reduces absorption. I have moved my slide, don't worry. So there is decreased absorption, of course. There's gut dysbiosis, and the symptoms that will show will be anorexia, nausea, vomiting, diarrhea. Diarrhea definitely now leads to other complications, of course. Um, Skin manifestations will be like dry skin, as well. Retinitis, echomiosis, they'll have fatigue, increased somnolences, failure to thrive. I have one particular patient who's maintained the same weight all through. Without edema, it's the same, like leading to normal. We did TSH the other day. In this case, the thyroid function test, somewhat deranged, leading to what we call hyperthyroidism, not hyperparathyroidism, hyperthyroidism. So muscle wasting started, corrected that by prescription of thyroxine, and up went up on his on her sorry on her protein intake. We went all the way to 1.7 grams per kg ideal body weight per day. But since that time, and even prescription of it, she's maintained the same weight, but she's getting catexic in the process. So they get failure to thrive, and that is how it will show. Other complications, uremic pericarditis, which will complicate the cardiac tamponade and possibly resulting in death. And need they will always need dialysis, and half the time, dependent on how the patient presents, they'll even need longer hours of dialysis because of the decreased cardiac output for this patient. So um, they have to have consistent, the word here is consistent, probiotics. The pericarditis here can actually lead to infective pericarditis, which is, well, damaging for them. The other complication is uremic neuropathy, encephalopathy being one of those which will present as coma and can lead to death. And there's also peripheral neuropathy, like I explained now with my patient who developed atherosclerosis. And we started treating with B1, B6, and B12 and pregabalin. Sensory disturbance will cause the restless leg or burning feet syndrome, which I just explained, which we are now treating with either pregabalin, gabapentin, which is the last resort because now that's a DDA drug, and now a combination of B1, B6, and B12. This we've talked about more often than not the last couple of lectures. Protein energy malnutrition, which will come secondary to low intake, reduced absorption and digestion, metabolic acidosis, and well, this is strongly correlated with mortality. And what we best get to do is monitor creatinine, albumin, prealbumin, protein intake, dependent on how and where your patient presents. You have to know where to target, whether it's 1.5 to 2 grams on dialysis maintenance, or zero point 0.8 to 1 gram. They're not on any form of modality entirely. And maintaining energy intake at between 30 to 35 kilocalories per kg ideal body weight per day. Platelet dysfunction, which is normally induced by uremia, and that will lead tendency to bleeding. And there's no specific therapy for this particular class of patients if they are symptomatic. So if they are symptomatic, basically you'll see that from their CBC and differentials and, well, the tendency of bleeding, they'll need platelet transfusion. Half the time pre-op if they are not on dialysis, or intra-dialysis if they are, of course, on maintenance hemodialysis, or chronic HD or PD. So, of course, now how you do that is transfusion, desmopressin, um, precipitate, and dialysis. Those things will definitely have to go all together. So this is a pictorial of exactly what you'll expect with CKD. On one end, metabolic disorders with osteodystrophy, increased inflammation, basically chronic dyslipidemia, leading to coronary heart disease. Basically, that's an increased mortality case. Congestive heart failure, that's an increased mortality case. On the other end, a CKD will lead to anemia, which, if not corrected in time, leads to cardiac ischemia, um, again leading to left ventricular hypertrophy, which goes all the way to congestive heart failure, and sadly, if not well maintained and, well, followed up, of course, mortality. All right. So we have to be very keen. We have to work with these patients closely because, well, I don't know why, but more often than not, these patients will open up to us uh, more times than any other particular cadre. But hey, that is what it is, and we have to ensure that we work with them, and I mean closely. So the mainstay treatment in chronic in CKD complications, for example, osteodystrophy, we've talked about this, so this is basically a summary. Osteodystrophy, we look at the D supplements, and they have to be active D3. So in this case, you're looking at calcitrol, you're looking at calcium salts, giving elemental calcium to a max of 2,000 milligrams, and intestinal phosphate binder, Sebilama or calcium carbonate from actual terms. Anemia, you have to combine erythropoietin and iron sucrose, and a HB less than 7. We do not dialyze without transfusing. All right, so transfusion in urgent cases. Cardiovascular issues, we have to look at statins. So in this case, you're looking at BP control, you're looking at triglycerides control, and you're looking at maintaining a low LDL. All right, so looking at all those factors from that perspective. And dyslipidemia, of course, you're looking at statins and fibrates as well. So that marks the end of this particular presentation. Questions and comments are welcome. Any questions or comments?
Hello, Grace.
Yes,
I'm Ivy, and I'm not sure whether you can hear me well. Kunanyesha.
I can hear you loud and clear, my dear.
Okay, thank you for the presentation. So I wanted to inquire something from you. I recently came across a patient who has cysts on both kidneys, and
Listening.
then the UECs, sodium was abnormal at 13.1 millimoles,
Mm-hmm.
I mean 131. And
Mm-hmm.
then potassium was normal at 3.7.
Mm-hmm.
And then chloride was abnormal at 93. It
Mm-hmm.
was low.
Mm-hmm.
Urea was abnormal. It was at 13.0, so elevated. And
Mm-hmm.
also the creatinine was elevated at 400 and 495.
Mm-hmm.
So what do you, and the patient is obese,
Mm-hmm.
um, and also is also hypertensive and has a family history where
Mm-hmm.
the mother also died of end stage renal disease. So what do you do with such a patient?
Okay. One. Remember when I said we have to look at it from a multidisciplinary approach. So
Yes.
you have to target what will be influenced. You have to identify, of course, by assessment. You have to identify what does this patient need from my perspective, from me. What does this patient need from me? What will kill this patient if I do not intervene? That's number one. Number two, you have to do it from a multidisciplinary approach, because if you are talking about cyst, then this is polycystic kidney disease for your patient. Is that the diagnosis?
Yes.
All right. So from there, then I would look at what are the interventions I need to input, so long as far as polycystic kidney disease is concerned. All right.
Uh-huh.
You understand the idea?
Yes.
Do you have a nephrologist in your facility, or can the patient first see a nephrologist? Considering the hypertension in this case, it needs to be classified whether it is systemic or it is portal, whether it is resistant.
Uh, the patient, I think, was just being seen by a general doctor and then referred to the nutritionist.
Mm-hmm.
Yeah, so before I, that is what I got from uh, from the whole thing. The patient was just sent and told to find a nutritionist so that she can be assisted in terms of diet preparation and also what she needs to do in terms of lifestyle to help her live a little bit normally.
All right. So normal is not exactly the word I would use. There's a new normal for each CKD patient. What you need to do is find out whether this patient is at risk of protein energy wasting. So you have to do the MIS scoring. You have to do an SGA, and from there you can actually generate or calculate a diet plan from the needs of this patient. That means you need albumin levels, you need this is polycystic kidney disease. Let me see. You need CBC with differentials. You need LFTs, absolutely. Also need to know the size of the kidneys. All
Okay.
right, and you also have to figure out whether the patient has a residual renal function.
Okay.
Most importantly, because the patient is predisposed to CKD because of the family history. All these
Right.
things to be factored in. If you do not, then we'll just be doing blanket. Ideal body weight, you need to use the adjusted body weight. If there are edematous, you need to do the nutritional focus physical exam. Are there other deficiencies we are looking for and we've not figured it out yet? Are there other deficiencies we might see? For example, if they tell you they are nauseated,